all of you. At the outset, I thank my friend Dr. GVK and his team for giving this opportunity. So, my talk is today low carbohydrate versus low calorie diet. So much talk on GLP-1 receptor analog, semaglutide, tirzepatide and SGLT inhibitors. But whatever the drug we are using, we have used earlier, we are going to use unless otherwise we adopt diet advice, no drug is going to help. That is the strongest message I want to pass on. How the low carbohydrate and low calorie diet is going to help in maintaining good control is the today's talk of mine. So, India is a carbohydrate heavy nation. Carbohydrate contribute 70 to 75% of the total dietary consumption in the India. So, we have to reduce instead of 75, less than 60 or less than 50 is good. So, we have to encourage the patient to reduce the carbohydrate intake. And recommendations as per various organizations, ADA 50 to 60%, British Diabetes Association 45 to 60%, EASD 45 to 60, Japan also 60, but in India only more than 65, whereas protein also very much less in India and fat also less than 21. So, consuming foods high in protein, low in carbohydrate and more fiber can help prevent unhealthy weight gain, thus reducing the risk of developing diabetes as well as obesity. Sugar causes diseases. High intake of added sugar causes dementia, diabetes, obesity, because excess sugar is getting converted to fat and protein. As long as your beta cells are coping up, then at one particular point of time the beta cells are not coping up, you develop hyperglycemia. So, diabetes, obesity, hypertriglyceridemia, low HDL, hypertension, CV death, etc. So, sugar causes disease. That may be, or otherwise I used to say tasty diet is dangerous diet. So, prefer healthy diet. Diet plays the dominant role in the management of diabetes rather than the drugs. Whatever the drug we have used, we are using, we are going to use in future also. In future another 4 or 5 years, lot of newer drugs are all going to come. So, whatever drug we are going to use, diet plays the dominant role. And understanding of healthy eating for prevention and management of type 2 diabetes has largely been derived from long-term prospective studies and limited evidence from the randomized control trials in general population, supplemented by evidence from people with type 2 diabetes. At the end I will show 2 case records. So, evidence from our own cases. A low carbohydrate diet for weight and glycemic control has gained popularity among some experts, clinicians and public. Others conclude that low carbohydrate diet combined with low saturated fat intake is best. So, low carbohydrate diet it is easy to advise. For example, if patient is taking 6 idlis, you will ask them to reduce 20%, 4 idli, 3 cups of rice, 2 cups of rice, or 4 chapati, 3 chapati. You need not calculate gram and calorie, etc. Then compensate with a lot of fiber or compensate with the protein. Emphasize vegetables low in carbohydrate, that is salad, greens, broccoli, cauliflower, etc. Protein in the form of meat, poultry, fish, shellfish or egg white, cheese, nuts and seeds. Some plants include your berries, some low glycemic index fruits also. Avoid starchy and sugary foods such as pasta, rice, potato and bread and sweets. There is no consistent definition of low carbohydrate. In this review, a low carbohydrate eating pattern is defined as reducing carbohydrate to 26 to 45% of the total calorie. That will reduce A1C, weight loss, lowered blood pressure, increased HDL and lowered triglyceride also. So, would you want to specifically say low carbohydrate, your 50 to 130 gram per day, and calorie wise more than 10 to less than 26% of calorie or total calorie. Very low calorie carbohydrate means 20 to 50, that is ketogenic diet, moderate carbohydrate and high carbohydrate. Here a very low carbohydrate intake less than 10% of the energy is also known as ketogenic diet. European or Canadian guidelines says 45 to 60% of total energy as carbohydrate, 10 to 20% as protein and less than 35% as fat. Indian guidelines say that recommend 50 to 60% energy from the carbohydrate, 10 to 15% from the protein, and less than 30% fat. So, percentage of carbohydrate in grams in total calorie. Suppose total calorie you are going to recommend 1200 to 2500, low calorie means 40%. Depending upon the 40%, you can increase the quantum of the carbohydrate. Stanley noted that low carbohydrate diet may help lower A1C, glycemic excursion, insulin resistance, liver enzyme associated with non-alcoholic fatty liver disease, need for insulin diabetes or medication, and cardiovascular risk, simultaneously increasing insulin sensitivity also. In fact, based on findings from the aptly named Indiana Diabetes Reversal Study, diabetes can be reversed for many patients. Even if this endpoint is not met, the benefits are still numerous. So, low carbohydrate diet is very good. So, in all population, manage weight. Foods, overall diet quantity matters, quality is relevant. Focus on foods, not isolated nutrients. Consider overall eating pattern. Non-dietary factors like your physical activity is important, smoking, other lifestyle matters. Specific considerations, coordinate dietary intake with the type and dose of medication. In specific approaches such as low carbohydrate nutrition or very low calorie diet, monitor glycemic control and adjust or stop medication. You are in a position to stop medication also to minimize hypoglycemia, especially sulfonylurea as well as insulin. So, not only the people with type 2 diabetes should adopt diet advice, the population at risk also should adopt diet advice. In general population also, otherwise diabetic diet good even for non-diabetic population. This is a statement by Dr. Professor Samji P. Moses 35 years before. Diabetic diet good even for non-diabetic population to avoid diabetes or to prevent diabetes. By CGM also, low carbohydrate diet. So, CGM is there is no glycemic variability, and for high carbohydrate diet there is gross glycemic variability, and for mean blood sugar of 123 for low carbohydrate diet there is no glycemic variability. Same mean blood sugar for high carbohydrate diet there is gross glycemic variability. And fasting glucose level CGM, very low carbohydrate, the fasting blood sugar is flat, as well as postprandial blood sugar also very flat when compared to high starchy diet or high sugar diet. So, guideline for carbohydrate for diabetes, 50 to 60% of the energy should be come from the carbohydrate. Carbohydrate should be complex in nature. It is not to be disaccharide or monosaccharide preparation. Monitoring carbohydrate whether by carbohydrate counting or experience based estimation. Carbohydrates from the food high in fiber, fruits, low glycemic index fruits are good. Substituting low glycemic load and low glycemic food is ideal. Non-nutritive sweeteners are ideal. So, regarding calorie, overweight people 20% of the or 20 calorie per kilogram body ideal body weight. Your ideal body weight people 30 calorie per kilogram body weight, sedentary etc. And low calorie means 610 kilocalorie a day was provided, 510 kilocalorie as a liquid formula diet, 100 kilocalorie as non-starchy, but very difficult to adopt. Theoretically we can talk, very difficult to adopt in long standing manner. At least 1200 or 1000 calorie we have to maintain. The formula diet consisted of 59 gram of carbohydrate, 11.4 gram of fat, 41 gram of protein. A low calorie diet was used as tool to study the mechanism involved. In one study, the patients with type 2 diabetes fasting plasma glucose normalized within 7 days of following low calorie diet. This normalization, though diet occurred despite simultaneous withdrawal of metformin therapy. Gradually over 8 weeks, glucose stimulated insulin secretion also returned to normal. Intrahepatic fat is used first and 30% decrease in hepatic fat. So, you need not give SGLT inhibitor, you need not give tirzepatide or semaglutide. Intrahepatic fat also getting reduced by 30%. In addition, pancreatic fat content fell over 8 weeks and beta cell function improved. This is because insulin secretory function was regained by redifferentiation after fat removal. Calorie reduction coincide with the carbohydrate restriction in many patients, many studies, even though it was not often specified in the dietary counseling. So, type 2 diabetes, liver fat increase, liver fat export increase, pancreatic fat, beta cell function declining. Once you pull down the liver fat with the help of diet and exercise. Pancreatic fat also comes down, beta cell function is getting improved. Very low calorie diet, 43% of carbohydrate, 34% of protein, 19.5% of fat, that is in the form of liquid, various trade names. In addition, up to 240 gram of non-starchy vegetables was consumed, making total calorie as 700 per day. So, by which your fasting blood sugar, HbA1c, but weight is not that much coming down, fasting and PP blood sugar is coming down. So, weight, responders, non-responders, weight is from baseline 98 kg coming down to 84 at 6 months. That non-responders also, non-responders means those who have not achieved fasting blood sugar less than 126, and all parameters are all coming down. Hepatic triglyceride is coming down, hepatic insulin resistance is coming down, hepatic VLDL is also coming down in the responders, as well as first phase of insulin secretion is getting improved from less level to higher level. Pancreatic triglyceride also coming down. A calorie restricted diet protocol in another study consisted of 55% of carbohydrate, 15% protein and 30%. Different authors goes for different percentage, but all are low. But all are responding for fasting blood sugar is coming down, PP also coming down, A1C also coming down. Sorry for this poster, but same thing. But diabetes remission and no glucose lowering medication. In control group there is no diabetes remission. In intermittent very low calorie diet, 2 days in a week and 4 days in a week, almost remission is 28%. No glucose lowering drug, 58% in the control group, whereas in intermittent 2 days a week and 4 days a week, the withdrawal of the sulfonylurea and insulin is much higher. Again, anthropometric measurement, healthy low fat, healthy low carbohydrate, weight is minus 5 kg, there minus 5 kg again, body mass index also minus 1.75, there at low carbohydrate diet, the body mass index is much more lower, 2. So, I will show some examples of some diets, high fiber, low calorie and low glycemic index food from 1500 to 1800 calorie. Carbohydrate is low glycemic index less than 5. So, this is quinoa, like our tena, sama, varage millets. This is South America millet. Quinoa, the glycemic index is 53 only, and black beans glycemic index 30 only, and lentils glycemic index 37, spinach glycemic index 15, broccoli glycemic index, and this one chickpeas, soya beans, fenugreek, rolled oats, and your bitter gourd, and mugil, our green dal, asparagus. So, they are all vegetable diets are superfoods. These are low glycemic index, low calorie diet, and you should fill our stomach with more of plant based diet rather than filling our modern diet like pizza, etc. We should change our mindset also towards good diet. I will show some of the examples also. So, this patient 16/2006, 168, 312, 420. I have given only pioglitazone metformin combination, but unfortunately he was taking juice every day, 4 banana and coconut biscuit for more than 2 years. After withdrawing this product, 1/6/2006, 23/6/2006, blood sugar fasting 89, 93, at that time A1C was 8.8. So, I have reduced the pioglitazone dose from 15 milligram to 7.5 milligram. Then subsequently 85 and 117 fasting and PP within 1 month further reduced the 7.5 as off. Then 107 postprandial 5.6 A1C, I start pioglitazone only nerves vitamin only. Now it has gone for remission. Remission was maintained for 5 years. So, 2006, 2011, 2012, then he started eating everything. In 2013, 247, 415, A1C 13.9. So, sustenance is very, very important. So, you have to persistently monitor the patient. There is remission, but if patient is not adherent to diet advice, again the A1C goes to 13.9. Again pioglitazone, metformin, no sulfonylurea, no insulin, subsequently maintaining. So, initially 8.8, maintaining less than 6.5, not maintaining the diet advice, going to 13.9, once adopted diet advice, even touching the 5.2 also. Otherwise, continuous follow-up is essential. We have to continuously monitor, maintain the good control. This is another patient I will show. This patient developed diabetes, 1 minute, 79, almost 46 years. He has records from 84, almost 40 years of record. So, he had uncontrolled diabetes during 94, 234, 236, 205, A1C 9.3. After modifying the dose and diet, all blood sugar less than 160, all A1C 6.6. Now, I stopped sulfonylurea also. Earlier, he was on semi-euglucon 1.5 in the morning, 1.5 in the night. Now, rosiglitazone, metformin, and subsequently A1C 6.5. Over 30 years, if he is maintaining diet advice, exercise, so from 94 to 2025, 2026, A1C is 6.6 only. Acarbose, metformin, vildagliptin, no SGLT inhibitor, no semaglutide, no tirzepatide. So, A1C is persistently monitored and maintained. During COVID, he had, because of steroid, 8.1. So, otherwise healthy low carbohydrate diet, low fat diet scores over associated with lower total mortality, and say no to excess carbohydrate and sugar intake. So, thank you. The doctor who the future will no longer treat the human frame, go back to previous slide, with the drugs, but rather will cure, prevent disease by nutrition. Thank you.